shorten the pathway to in the healthcare, and can lead to better decision making, better outcome measurements, and then better readjustment of the treatment and the interventions. So it's much more about logistic inside of the healthcare life cycle, how to optimize the healthcare life cycle, making more precise, making better decisions. Then comes the next level of AI on the top of all of that. The AI can go beyond the optimization in digital health of the resources, the optimization of the decision-making, by bringing a little bit more expertise and decision-making inside of that space of decision-making, by bringing more help, but also bringing more specialists in the space that are lacking a lot of specialists. For example, if you talk about mental health, we have a big discrepancy in the mental health, especially when it comes to the global south. We have less than 0.03 specialists in mental health, pediatricians, mental health specialists in the global south, across the global healthcare workforce that is dedicated to mental health in the world. That makes the digital and AI interventions that could lead to better relief, better intervention, better promotion of mental health conditions in the global south. That could be something that can be quickly deployed. Maybe it should not act in the space of the treatment, maybe not in the space of the re-education, but at least a couple of the elements of the mental health spectrum can be covered by the AI in digital health. That is an essential step towards the better mental health provision, for example, in that case, in the global south, and will reduce this inequity in the access to the healthcare workforce.
Thank you so much. Perhaps, Louise, you can give us also an insight about how can digital health contribute to the achievement of universal health coverage? We also do know that the 2030 Sustainable Development Agenda is something that all the countries have pledged and are working on achieving it. And they've also recognized that digitalization is something prominent. It is needed in order for us to achieve and work toward that agenda.
Okay, well, thank you very much for inviting me to be here. As in the introduction, I've been working with a Lancet and Financial Times commission called Governing Health Futures 2030, which looks at the intersection of digitalization and health. And the sort of premise of the commission's work was the huge potential that lies for digital technologies and data to accelerate progress towards universal health coverage. And so, as we've heard, there are so many different ways in which digital tools and data can expand coverage of health interventions, can reach underserved populations, can reduce the costs related to healthcare for many different populations. But I totally agree that we're so far away from universal benefits of digitalization. There are so many barriers that need to be overcome before we get anywhere near that. The only things I can really add are to say that for us, we looked at digital transformations of health systems within the broader context of digitalization, which affects every single part of our lives now. Even people who aren't yet connected or well connected to the internet will find that the environment they're living in, the policymaker decisions that are made about the services they receive, the information that they're going to get access to are all kind of shaped now by digitalization and the different actors that are powerful now within the digital ecosystem. So even if it's indirectly, digitalization is affecting, everything to do with our health and well-being in both positive and potentially negative ways. So the Commission kind of looked at that broader picture and how digitalization of health systems fits within that. And I just think a final point is that it's really important the way that digital technologies are giving more power to us as individuals, as patients and communities to become more informed about health and well-being and to manage our own health and well-being in new ways that we were never able to before. So there's this huge potential, and if only we could reduce those divides and make them available to everyone.
Thank you so much, Louise. And that brings me to my next discussion point, basically, which is what does it entail? We did hear that digital health is more than we might come across as applications or our mobile phones or health records, digital health records. It's even beyond that. And we also know that there are positive elements of it and there are negative elements of it, and that does impede its integration perhaps into the health systems. So perhaps my next question, what do we mean when we say that we want to digitally transform health systems? What can we expect from it in the future and at the moment? Perhaps I'll bring the floor back to Mahdi and we'll take it from there, Dr. Mahdi.
Thank you. So we started talking about digital health systems decades ago. And we have been in different directions, to be frankly, very fragmented, with no clear goal set up for a common effort or a global effort for this digitalization and digital transformation process. I think recently we've started talking about the learning health systems. And learning health systems is a quite good concept for me, where we learn on the evidence base that are generated from research inside of the health system, and we bring back these evidence inside of the health system to deliver better healthcare services. The acceleration of building learning health system is a very nice step towards digitalization of health system. That requires that all the data, all the workflow are well designed, are well shaped, and that they are integrated in each other. I think we need a holistic approach. We need to define what is digital health system overall. What is the digital transformation? Should we simply talk about data, workflow, process, how we deliver the services and the interventions? Or should we also talk about the perspective from the patient side of what is a digital health system? I think we need to bring all these definitions that are around there in the domain together to create one unified vision regarding digital health system that can bring the healthcare insurance, the healthcare providers, the medical practitioners, the researchers, the policymakers, and the patients in around the same table, sharing the same definition of what is a digital health system, rather than competing each other. Sometimes it's about the interoperability, other times it's about digitalization of the records or digital health systems. So I think it requires different building blocks. It requires a better vision and coordinated vision to start thinking what is in reality digital health system and how to achieve that. And many experiments are going at least at the global south in order to achieve this one vision of digital health system. And that's very strange or very surprising that when we look at the maturity level of DHS in the global south, we often find that they have achieved much better than the global north in the digitalization process, simply because they are starting from scratch and there is no forced fit inside the digitalization process or the digital transformation process that is happening in the global north. So if you look in Switzerland, where I'm coming from, in Switzerland, we have tried different sub-projects for the digitalization of health records, simply health records, and we end up by giving up because we do not do the digitalization as a vision. We do the digitalization as a requirement. So we think that by taking the analog words, which is the data that we have today, into files, and that we bring it to the digital, that's the transformation. I think the transformation is much more about than simply bringing the data from the analog to the digital. Is spirit. I think it's a kind of thinking, and it should be done by design, or it will be a big failure for me.
Thank you so much. And that brings me to the fact that in this panel, we have a lot of different experiences and a lot of different expertise. So I'll give the floor to Alba to tell us more from her own experience. What does digital transformation entail?
Well, I must say that I don't have that much experience. So first of all, thank you for having me here today. And well, as said previously, it's difficult to define what is digital transformation. We have to differentiate between digitization and transforming the paper data to digitalized way, but also to the digital transformation. So I think it's the use of digital technologies and data to improve the health system. So it has to give results also both for the health professionals and for the patients, so make the clinicians their work day-to-day basis easier, and also to provide a more personalized diagnosis and treatment to the patients. So I think it's something that we have to ensure that it's implemented in an equitable and a sustainable way to ensure that everyone can benefit from this digital transformation.
Excellent. And you brought us exactly where I wanted to go, the implementation. How do you make sure that digital health is accessible, equitable to all those in need? And that requires a lot of barriers, challenges that is present at the moment. So perhaps, Louise, if you can walk us a little bit more about what barriers exist and how can we, and what are the current challenges that we are in face of at the moment that prevents us from transforming the health systems or digitalizing the health systems?
Okay. I mean, there are many different types of barriers. I'll try and sort of mention some of them. I mean, there are obvious ones around sort of political barriers, about the level of political will and support within a country for digitalization of health systems and to use digital tools in a way that benefit public health. So there's always potentially going to be political barriers to change. Digitalization requires lots of things to change and for power to shift between different actors potentially. So there may be resistance also potentially from the health workforce who have to adapt their ways of working and sort of learn how to use new tools. There are financial barriers. For example, we've done some research with an organization called Transform Health that found that very few countries are tracking how much investment they're making into digital transformations of health. So it's very difficult to know where the sort of funding gaps are and how they can be filled because that information isn't being routinely tracked by national governments or donor agencies. I think it's of a huge number of the barriers are obviously technical that need to be overcome to improve the interoperability of different health information systems, for example. But I think for me, one of the sort of most stark barriers that we need to address is around the sort of governance of digital transformations of health. There are huge sort of trust deficits among populations, among health workforce, around the adoption of digital technologies and data, particularly around data and how it's collected and used. I think if people are not confident that their most sensitive and personal data is going to be treated safely and only used in support of their or their community's health, they're not going to be willing to share their data. They're going to be suspicious of different digital tools. There's obviously sort of changes in the sort of the ecosystem of actors. There's so many new types of organizations that are now interested in delivering healthcare because of the opportunities around digitalization. So there's how we govern the kind of the roles that all of these different actors play. I think that's a huge barrier to sharing innovations and data, for example, across and between countries. So that's just some of the examples of some of the barriers that we need to overcome.
That makes me direct a question to Dr. Janos. So you come from a background where you have the Estonian experience of implementing digital health in the country. So can you walk us through that experience? What challenges was faced? What was a success? What can we learn out of it?
Yes, thank you. Estonia has gone through the maybe long and fascinating path. And if we say where we started, it was pretty much the same as it was mentioned from digitalization, but also the mindset, because Estonia, when it got re-independent from Soviet Union and Soviet Union fell apart, the actual level of the communication and the technology was very low. So just to bring you an example, in Estonia also, you had to actually queue to get the fixed telephone line to installed in your apartment for maybe 20 years sometimes. And suddenly when we had a mobile technologies, so we skipped over. So suddenly everybody had mobile phones and you didn't need any more fixed lines. Or take payments in Soviet Union, you didn't have actually checks to pay for your bills. And suddenly everybody had credit cards because we skipped this phase. So this is just to also to emphasize that it depends where you start. And so about the digitization in healthcare, it's not, you cannot take it as a separate from the general approach or general situation in the country. So, and it depends on so many things, and it was mentioned about the attitude, but also in Estonia, as we started to implement unique personalized ID numbers, which is actually basis of our system. And it happened not because of healthcare or other applications, it happened because of banks said, we think this is a good idea when what the government was proposing. And then it actually went viral. In less than 1 year, nearly majority of people actually had ID cards with chip, and this was issued and supported, the issuance was supported by the banks, because they just wanted to be more efficient, to go actually online, and to close their physical offices. And this was surprisingly one of the very important steps, because if you take, for example, Finland, which has had the ID number and ID cards for a long time, but they still don't have this penetration as we have here in Estonia, nearly 100% penetration of ID cards and using ID number, and all our systems, not only in a social and sphere and healthcare, is based on this single unique number which each person gets at birth. So it helps you identify the person, but it brings also to us to this different approach from different countries, like in UK or in Germany. Nobody actually can imagine that government can actually have a control over your data in this way and your personality. I know even in UK it was actually discussed in some years ago to introduce the common ID number or personal ID number, but it was skipped. So this is very important. But Estonia, yes, we at the moment where we stand, we started the major digitization in healthcare, not as a first step, but from 2005, 2006. And since then, we have made some progress, especially based on our general e-health governance system, or e-governance system, not health governance, e-governance system, which means that we also healthcare taking advantage on this. And of course, we have all data digitized, but doesn't mean that we have all digitized is data. So it's as I said, it's very often it's just analog text, which is in digital form. So we are working on this, and we need to have a normalization of the data, what we have, and also in some elements in laboratory medicine or in prescriptions, which are 100% electronic, we are pretty advanced and even unique in European, where we can actually cross-border use and prescribe prescription and exercising these prescriptions with Finland, for example. Better I stop here, and maybe we can just give some more examples later.
I've heard barriers related to data surveillance, issues with e-governance, finances. So perhaps if Alba can walk us through not how can we tackle those barriers, but from an implementation perspective and policy perspectives, what is needed to tackle them? What can we introduce, or how can we combat them?
So I think there are many factors to be considered. First of all, a reimbursement procedure is needed because, well, recently Germany is a great example with the big experiment, but in the majority of European countries is not still implemented a reimbursement procedure for digital technologies. So it's a huge barrier for the innovation development of the health systems. And also, as EDA, the European project we are coordinating with, also with the Scanbalt. So we are trying to scale up the dialogue of the European health data space to make it a reality. So to have an harmonized policies for that data sharing and try to analyze all these barriers and see how can we connect and make interoperable this data around all the European countries. So data is the heart of innovation. It is needed for every step of the life cycle of digital technologies. So I think it's something that is in the center for improving the patient outcomes. So I think that this harmonizing the digital policies on data sharing is the most important thing that to be done from the beginning.
Talking about better patient outcomes, what do you think the patient thinks about the data usage throughout? So I'd like to direct the question to Dr. Mahdi, perhaps. And from a patient-centered perspective and the usage of data across borders, how does that benefit the patient? And where can we draw the line, basically?
I'll give a very concrete example of previous work I've been doing at the Hospital of Geneva, where we have been dealing with patients in late stage of neurodegenerative disease with no communication abilities. And then during that research projects, we have been working towards the implementation of patient outcomes monitoring by the usage of wearables and video monitoring in order to detect if the patient is in stress or under stressful situation or in pain, in order to act and intervene accordingly by giving by making some pain relief interventions. What we used to do is a kind of European medical scales named Dolo Plus that could be done once a day, every 24 hours, very time consuming. And then we can miss the time interval where the patient was in pain. So this small project at very small scale within the palliative care unit then start growing slowly till reaching the ICU unit during the COVID crisis. So we started at a very small scale, and then the evidence-based give us the opportunity to make these projects getting integrated in different other units. I think the patient in this case with no communication abilities is not able to talk about the benefits or the outcome. But this is a concrete example where we can see an immediate solutions to some unresolved issues. And I think there where we have the nail, we need to hit that nail where the patient is looking for a better improved situation, a better improved interventions, or a more suitable consideration of his preference, or taking into consideration the patient adherence and the backgrounds, and more customization of all the risk assessment that we do when we do some investigations with our patients. I think that if we start from by tackling these issues, by talking to the patient directly with the benefit that they could get from the different digital interventions or different digital risk management process that we can implement, he can see, measure, and understand the immediate benefit of the digital interventions that we are building. And then he can be an early adopter, if not an advocator, for these kind of digital interventions, meaning he will be looking for this level of advancement in the implementation, at the implementation level, and he will judge the quality of intervention accordingly. The patient-reported outcome monitoring recently moved from healthcare insurance tool for reimbursement decision-making to measurement of the quality of the interventions, but also measurement of the quality of the healthcare provided within different hospitals. So we are seeing the shift happening, sometimes happening due to the patient pressure rather than patient outcome, patient pressure, because they are asking for better healthcare, more personalized healthcare, and more fair access to the better healthcare. So the shift, we have the tools, we have the data, we have the process, we have the knowledge. And I think what we need is that there is a bigger uptake, there is a bigger asking for, and we need to make it very natural, very organic, coming from the patient side rather than from the medical side at some point, because they are our end users, meaning at the end, we are delivering all these things, all these services for the patient themselves. So if we do not integrate their voice from the early beginning in the design of the digital interventions, we may end up with some bad results. I think I'll advocate for that. I think that the patient voice is an important step in order to optimize the patient outcomes later.
Thank you so much. Perhaps my third point of discussion out of this panel is the health workers. As a fellow medical student myself, and I believe most of the room as well would agree with me, why should health workers be concerned with digitalization? Why should we learn about digital health within our medical curriculum, for example, and even beyond in our training posts? So I'll direct the question to Louise to walk us through that a little bit.
I'm probably the only person on the panel who's not a medical professional, but I can speak. We had a workshop yesterday on digital health, and I shared a slide from a survey that we did with IFMSA, which contributed to the Lancet Commission's report. And we asked members of IFMSA a number of questions around their perceptions of digital health and their level of sort of training and skills and education that they feel they're getting about digital health in their curriculum. And we found that on one hand, there was a sort of huge level of optimism about the potential for digital transformations to both improve their work, but also the health outcomes of the people that they're working with. But on the other hand, they pretty much like unanimously said that they were not getting enough quality education, training, capacity building around digital transformations of health in their current medical education. So I think it's obviously an interest of importance to the future workforce and the current workforce. And you have an important role, I think, in terms of demanding better education, training and skills so that you're prepared to work in an environment where the sort of level of digitalization is only going to increase. I think the health workforce is also unique in terms of its perspective on how effective different digital types of approaches to digitalization and different digital health interventions are. You're the ones who'll know like how easy they are to use. Are they making your jobs easier or more difficult? Are they benefiting the patients, or are there certain groups of patients who they don't work for? And that kind of information needs to be fed back. So I think your voice is really important in terms of shaping the future direction of digitalization of health systems. So you should be caring about it and sort of concerned about whether it's making health outcomes better and making your jobs easier.
And to Dr. Janos, what do you think are the challenges and struggles that you face while preparing the workforce to utilize the digital technology in Estonia?
Sorry. We have a good example from the early days, like back some 16 years ago when we started the major digitalization, and there was a quite strong opposition from doctors' side. And then you need to look behind all the good things that can come out, and what is a personal approach, and what it means for the sort of health workers. And this time we understood that there was clearly reason is that in digital all logs are later available, whatever you do with documentation. And this means that with a paper, you can sometimes change. If you have not filled in the diary, you can do it later. Maybe after you made the intervention already. If you have some complications, you can actually adapt accordingly. But in digital, everything's on. And the other thing is what is important, which is concerning the data privacy of the patients. Earlier, in a clinic or a hospital, nobody knew who is looking your personal health data. If it's somewhere available and you are authorized to take a look, you can do this. But now in Estonia, no doctor, no nurse can actually, if you ask somebody, even colleague, can you, I have a relative actually in a ward. Can you tell me something about his case? No way. Because this, if the person is not any relevance to the case, she or he cannot do this. These are restrictions, and it is actually major shift in the practice. The other thing is we have to be cautious what will be the workload to start to use the new digital tools and then the digitalization. So if you go with the tool or any digital sort of app, which is not easy to use, is not intuitive to use, then it might take a lot of time to get used to use it. And maybe we should just put more effort to the actually the user interfaces, how logical they are, how intuitive this is important, most important, because if it's actually adds on or and takes more efforts to use it, then people simply don't take it. This is most practical cases we have seen. If it needs more time to actually use a digital tool, then people are reluctant to take it. And believe me, doctors in particular can always say and find excuse why they don't use this.
Thank you so much. And I redirect the question to Dr. Mahdi, perhaps, since he is a practicing doctor and he made the switch or to transition to the world of artificial intelligence and digital health. What do you think are the current struggles in the workforce? And from your own experience, how did you transition into that shift, and what led you to that shift, perhaps?
A lot. So, frankly, there is a big disruption between what is happening in research space and then practitioner space. So if you go to pharmaceutical research space, you'll see a lot of tools that have been used a decade ago. AI for drug discovery, it's a very common tool. But if you talk to pharmaceutical students, you'll find that most of them have never seen any kind of these tools inside of their educational pathway. So I can relate to that also in the medical schools and students, meaning if you talk about AI systems for cancer detection, diagnosis. So I don't know how many of you have seen these tools in reality, but the access to these tools is very restricted and you don't have it in all different settings. So the healthcare workforce today is equipped with the basic knowledge, but it's not equipped with the knowledge to quickly embark on the AI trip. But it's besides of the this issue, we have, as you have been saying about, we skip some steps. We are already in more or less preparing to skip the step of digital health and AI and to go beyond that to the quantum computing. So quantum computing, quantum supremacy that have been declared by Google have been reached by Google months ago by this spectacular operation of protein folding that have been announced by Google. So I think that frankly, we need to skip the digital health somehow and AI, especially in research, and we start preparing ourselves to the next, directly to the next step about the impact of the quantum computing that we will have on the healthcare, because that will be a big disruption for the entire medical research, pharmaceutical research, and that will lead to quicker evidence, quicker treatment discoveries. That means quicker clinical trials and maybe even bigger simulation platforms, either in the brain or the health or drug simulations. So this is something, these small points that I've been talking about, I think that are essential elements that need to be thought, but are also shown to all students and the existing healthcare workforce to equip them, but also to make them, to raise the awareness that disruption and the medical domain is not a domain that is protected from disruption. I know that we keep saying that we will never skip the human element inside of the medical sector, and that's true. but what is the exact role, how this role will be shaped according to the new technology. We need to raise the awareness, and also we need to say that where there is no human, the machine can be very dangerous. Meaning a lot of patients are Googling their conditions, and then they are trying to make some self-medication in different places, especially in the global south. And this is a big issue. So it's not about the machine replacing the doctor. It's about the patient replacing the visit or the treatment or the diagnosis by something that should not happen. And that's the nature. Hate the empty spaces. We need to occupy that space, and we need to occupy professionally by being aware of the existence of these kind of meaning issues, but also of what is coming beyond digital and AI in order to be prepared for the next wave, that it can be very disruptive for the healthcare domain.
Thank you so much. I 100% agree. Awareness of the existing, awareness of the limitation that is imposed by digital health, the dangers that it imposes if we don't have proper mechanisms to counter that is indeed important. So I will give now the floor to our audience here. If you would like to direct the question to our panelists, please feel free to raise your hand and we will give you immediately the microphone.
Hello. Hello, Sam Al-Horani here. I have a question. So you've mentioned that one of the issues facing digital transformation is the lack of transparency in how the data is being processed, or even when patients are afraid of data breaches. So my question is, how would you properly communicate to your patients as to how their data is being processed throughout the management plan, especially because I really liked how you worked with the neurocognitive disorders. So we have to take into account that some patients would have cognitive decline or like executive function decline. So how would you communicate to the general patients and the patients with cognitive disorders as to how their data is being processed, and how would you decrease their perceived fear of data breach? Thank you.
Well, I think this is a very fundamental question about informed consent and how make it informed consent really informed, not only consent. And I don't think there is a good answer on this. It's actually depends on the circumstances. And here it's a human factor came in. The human has to decide in which level and how detailed you will explain this and in which manner. Otherwise, it will be, you see, the recent examples from ChatGPT has been that if you ask a question, you get a very clear and self-confident answer, which very often is rubbish. But somebody has to judge it. And if you are not able to judge what the counterpart, which has actually been going through whole content of internet until 2021, is telling you, and you are not able to judge. This is again, there is a human touch and the art of the medical professional to understand in which level and which way it has to be explained, and to be confident that the person actually gets informed consent.
Thank you for the question. So just bring two elements. From my perspective, I still struggling with the area that the patient don't have direct access to his own data and don't master this kind of access, meaning he decide about giving you access or not. We should not, and should not the opposite way. If we do it that way, that means that the patient is the only and the one stakeholder that got the final rights on his own data. And that's how we should implement it. It should be like that. Beyond that, as you said, meaning when it comes to the clinical trials, where I've been involved in, at least with cognitive disorders, with very late neurodegenerative disease, meaning the results that showing that we have less agitation, we have what we considered as behavioral and psychological syndrome of dementia, was not a BBSD, but was pain agitation. We have much less we have much easy to handle patients because the intervention is very effective and the data being used in a responsible manner to generate an immediate benefit to the patient. The family of the patient who are responsible of giving the consent, since the patient was not able to give that, was asking for even increase the amount of data later once the patient is discharged from the palliative care unit at home. So we got requests from the families because they have seen the effectiveness of the approach. So I think as long as the patient is aware about the benefits that he is gaining from his data, that's fine. That's the point. Second, the last point is about the data stigma. We have been, as my colleague is saying, very confident that data will benefit to the patient, and we have often been in that space of the data stigma, meaning we do not consider that aspects. It doesn't mean that you need to leak the data or to talk about the patients or the use case that there is the stigma, that the stigma is happening. The patient can feel by himself that there is issues, and we need to be very concerned about the quality of data, the quantity of the data, and the stigma that can be generated. Meaning, if you talk to a schizophrenic and you talk about his own data, you may have even impact and worsen the situation or the mental situation of the patient. So we have to be very humanistic approach, centered approach to the patients. And we have to avoid, I think, some of these situations need to be avoided, especially with the cognitive or mental disorders, because that can get an immediate impact on the conditions of the patients. So yeah, it's a case by case. There is no first fit. And I don't see a general framework for that. It's like how the patient select a doctor or medical doctor. It's based on trust. It's based on this human relationship. And I think that we need to keep this touch inside of the data sharing process later on.
Maybe I can add just on this issue of data stigmatization, and a good example is genetic data. Genetic data on potential susceptibility risks. So there has been discussion now ongoing for decades, whether you should convey this data if you know this, if there is no benefit for the patient, if the patient cannot actually do anything to prevent the condition. Is it actually fair to tell this data or let him or her live without this knowledge? Because it's an additional mental burden. So this, I don't think there is a good answer to this.
Hello, thank you for your time, for coming here to our conference. Martin from Slomsa, Slovakia. I have a question. It's kind of follow-up for your question, but information in general is a type of something that can be monetized. And my question leads maybe to Lucy, but it's for the discussion to everybody. 20 years ago, it would be unimaginable for us to share our position, like global positioning, our photos online, our personal information. But now it became a standard for the cookies, for example. And I want to ask if there is a future in which our health data can be used this way, and maybe to serve as a devil advocate here, could this be a positive thing that tailoring the products that we are getting to our health needs as a part of information the company is getting from us?
It's a big question, but I think kind of what you're indicating is a really important point about the fact that there are so many different types of health data or health related data that we're generating outside of the health system. So every time we're searching for things online, and as you said, like clicking yes to all the cookies, because I don't read them. I just say yes. We're generating data that someone out there can potentially use to make money from, or to down the line make decisions that will affect our health and my health and well-being. if that information about, my search history got into the hands of a health insurance company, I mean, who knows what decisions they'd make based on that. So I think that's why, as our commission and many other organizations, we've been calling for a stronger approach to data governance more generally, and for global norms and standards that can guide countries in terms of governance of data and health data in particular. I think health data is, because of the sort of sensitive and impersonal nature of it, requires its own sort of set of governance and standards and norms. And the Lancet Commission made a set of recommendations about a solidarity-based approach to data governance, which may not be something that's supported by everyone, but it's around sort of trying to find that right balance between protecting individuals' personal, their human rights, their privacy and the security of their data, but also not locking data down so much that we can't derive public benefits from it. So finding that balance so that people do feel confident, that they trust that their data is being handled not only by their health system, but by corporations, by all sorts of, by their governments, whoever's handling their data. So we need, I think, this sort of comprehensive approach to data governance, because health data is everything and everywhere now. It's not just the data that your physician holds. I'm not sure if I answered your question.
Maybe to add that this is actually the main topic with the process, what we call today the European Health Data Space. It's actually covering a lot of issues, but one of the main topic is where to find balance. And it's back to the informed consent. And if we speak about the primary or secondary use of health data, the primary use is actually for your own benefit. It has been always actually personalized. But the other is a secondary use, where you can actually have either identifiable personalized data, or it's anonymized data or anonymous data. And the case of latter, there are different views in Europe. As it's in the southern part of Europe, you have more like an opt-in, that each time somebody wants to use this data, has to ask a new informed consent, but then has to be an intermediary to somebody who knows whose data they are. And the other approach is what we have exercising mostly here in the northern countries and in Estonia, is it's opt-out. If it's allowed by the law, then you can do this, and you don't need to ask each time a new informed consent. You ask to, if you do a research project, either commercial or non-commercial, you have to have just the ethics committee permission, and that's all. But this is a big issue in the whole topic of European health data space and using cross-border the health data.
Just while you are working, just to tell you that you are already sharing some of your health data. If you have a Fitbit or if you have an Apple Watch, you are giving your heart rate, you are giving some electrodermal activity, you are giving, so you are already into that. All of us are into that at some point with our own consent.
I was wondering if any of you have views on the influence of digital health on traditional medicine and culture.
Yes. So we recently got in charge a big project with the Global Center of Traditional Medicine that is led by WHO in India, to understand what is the relationship between the artificial intelligence, digital, and the traditional medicine. So how to modernize the traditional medicine, which is two contradictory words in the same sentence. How to modernize the traditional medicine by bringing that. So I'll jump back to the first example about AI and drug discovery, and then you can see the immediate relationship between AI drug discovery and AI in traditional medicine for drug discoveries. But not only that, the evidence-based approach in the Occidental medicine or classical medicine is in opposition with the practice-based evidence that is coming into traditional medicine, where we can run clinical trials, meaning traditional medicine is by essence against the clinical trials. So we can't extract this evidence. So in our mission is to understand if there is any different way to collect these evidence of the effectiveness and efficiency of traditional medicine in that space, but also to restructure that space to be able to integrate all the tacit knowledge that we have in that area, to bring it in parallel with the implicit knowledge that we have it, and to link the entire ecosystem with the existing research that we have. So yes, it's a starting block. So we just started this project like 2 months ago, and hopefully we'll be able to get first results by August in during the G20 Indian presentation of the Global Center of Traditional Medicine. One essential piece that I can announce is that we are working in, I don't know if you heard about the BioGPT released by Microsoft a month ago. Yeah. So we are working on a similar approach to build the traditional medicine GPT. So the TM GPT that will be hopefully released in August, that will enable and make it more accessible to implement new research in AI in the traditional medicine space.
We have more questions.
Yes, thank you very much. My question is, with the advent of artificial intelligence currently happening, I was wondering what your vision is on the eventual application of AI in healthcare, and what should be done to have future healthcare professionals be prepared for this application?
So, well, I'm not a health professional, so my vision will be more general. But I think that artificial intelligence implemented to the health system can help their work for health professionals, because it can accelerate the diagnosis, also increase the accuracy, so resulting in a more personalized treatment and helping decision making to health professionals. So I think it's something that can avoid a duplication of processes and save time for doctors to be more time with patients. So it's something that can be really beneficial if it's well implemented. But yeah, we have to definitely we have to change a lot the education curricula and in the universities. We cannot put all the responsibility on the health professionals. We have to start by changing the education, and then coming from the organization and hospitals, providing health professionals and clinicians of time and incentives for them to continue learning and updating on the new trends and digitalization systems. So I think it can be very beneficial, but with a background of education in the health professionals.
Maybe I just can just continue from here, but there is another sort of side of the coin, which is at how you control what the AI is doing. Is it two types? If it's just the sort of administrative part of the process, then maybe it's not so important. But it's when you comes to the advising or making decisions on the diagnosis on treatment, then you are in a phase that if you cannot control this, what if you have a fixed algorithm, digital devices or digital software, then you at least know where to find how to check it. But if it's AI and learning sort of software, intelligent, then how you be sure that this what the AI is deciding is correct and it's according to the current level of knowledge? And this is what is a problem. If you look to the medical device regulation, what has been adopted recently in 2017 in European Union, and now just implemented last year as a medical device, all software what you use and which gives you any input to the decision making in diagnostics and treatment is considered as a medical device. And now you, in order to actually launch it in European markets at least, you need CE mark. And to get the CE mark, you have to actually prove clinically that there's no risks, that you are on top of the control of this software, that you know what it's actually, what are the expected outcomes. And with AI, can you do this today? I'm not sure.
I was just going to add that from the perspective of the Commission, we were sort of calling for approaches to governance that are able to keep up with the pace of innovation. Like you were talking about things like quantum computing. Most digital health strategies don't even talk about AI yet, let alone like quantum computing. So, so we need to kind of come up with some general principles to assess things like AI. And the kind of proposal that the Commission made was to try and assess things like AI and any kind of digital tool against health for all values. So if we're thinking about the ultimate outcome being better health and well-being for everyone, we want, you know, to follow principles such as equity, human rights, inclusion, solidarity, and democracy, I think are the main ones that we focused on. So whether it's the data that's going into training the algorithms, whether it's the development of the algorithm, how that information's used, we would sort of suggest that all of those need to be assessed. And I think, you know, that aligns with what you've said, that is it, was it developed with a human rights principles? Is it delivering equitable benefits? Is it avoiding discrimination? So we can try and keep up with all of these different changes. If we have our core values kind of agreed, then we have something to judge anything against.
I'll just add something. So with the new technology comes the benefit, but also comes the risk and negative aspects. And as long as we are ready to admit that there is a big risk there, we can benefit from it. It's like gambling, more or less, but it's with more, maybe with more benefit for that, especially for the AI. Now, 4 years ago, we got European Commission regulation on AI in clinical trials. And 6 months after the regulation appears and then was in force, we start working on what we call synthetic data. Synthetic data is similar to patient data, but it's synthetic data. So we avoided the entire regulation by just creating a new notion that was not included in that, inside of that regulation. It's very easy, meaning if you look at the cybersecurity 20 years ago, it's exactly the same thing. You will create, patch your antivirus, firewall, whatever it is, and then we will find another way to do the things that we are doing. So that's, we need to admit it, because this is the digital space. This is how it is. And then it need to be considered as it is. Now we need to bring more dynamicity in the work we are doing, because the digital space is very dynamic. And then today we are talking about AI. Next year, may we be talking about quantum, where there is no longer cybersecurity. We all know about that. The cryptography is no longer a thing if we have the quantum computing happening. So, and then within this this approach of the AI, what we need about more to be aware of is what are the, how far are we going inside of the ethical considerations we would like to embed inside of our AI approach? How far would we like to get the responsible AI as a community? I mean, because for the moment, the space is taken by Microsoft, by Google, by Elon Musk, rather than by the practitioners, the clinical researchers, and the patient themselves. So the people who are setting the rules are already playing with these rules. And then that need to be very clear, because they are working on the development of the AI. At some point, I think that we need to raise the awareness of this issue, and we need to think about seriously taking into consideration that the data and the AI in healthcare space should be firstly regulated internally before going outside and giving that the possibility to big players in the the big industrial and digital players.
One question here, yeah.
Okay. Hi, I'm Kosha from India, and I'm the IFMSA Liaison Officer for Medical Education Issues. I have 2 questions, if you don't mind, Arwa. The first being that I wanted to know if you have any reflections on the impact of the pandemic on either accelerating or implementation of digitalization in health with relation to patient compliance. And the second is related to students and how you think or you envision digital health to be involved in the curricula, as it's not conventionally a part of the core curricula. What competencies and what methodologies do you think can be innovated upon when we are thinking about including digital health in medical curricula? reflecting on the fact that most of our educators are currently not that competent with digital health and how to use the interfaces that you were talking about. Thank you.
I mean, I can just start a little bit by saying, I think that there shouldn't be just standalone modules on digital health anymore. I think it's so integral to every aspect of healthcare now. It should be something that's kind of integrated across the whole curriculum. And your first question, I've forgotten, but
If I may, it was just on how the pandemic has impacted the acceleration.
I mean, I think it's definitely accelerated the use by both medical practitioners and patients of digital tools that often people were very reluctant to use. I mean, I've seen that in the country where I live, and I'm sure others can speak to that, but people who were often reluctant to download apps and to have virtual consultations with doctors are now seeing that as normal, and their expectation is there now that this will continue and the quality and the cost and thing will just continue to improve.
So if just addressing the first question is, of course, it has been tremendous impact. If you see what happened in the first days of pandemic and globally, that not only in the medical field, but the actual digital virtual meetings, the actually workspace has changed. So, of course, it's actually diminished, but if you see how the number of teleconsultations, it was merely teleconsultations. In Estonia, the teleconsultations were not actually considered to be reimbursed by the public health insurance before the pandemic. Now it's actually already everyday practice. Although in most of the medical areas, it's said that you need at least one physical meeting to actually convert it, the contact to the teleconsultation. But now, if you take mental health, basically, you could do video conferencing. You get same information because you don't usually touch the patient. You don't measure anything. You don't take blood samples. The main instrument is to have an interview and just to make a physical sort of assessment of the behavior of the person. So, and what good example was actually what was said about the COVID passport, which was actually introduced in European Union. As you know, in European Union, the healthcare is responsibility of each member state. There's nothing nearly on the European Commission level or European level. And this was a great achievement, what we said. In 5 weeks, the governments could agree on the COVID passport, which was considered a great achievement in health data and healthcare area in digitalization in European Union.
Well, just to add another specific example, which was accelerated in Spain, related to the health system, it was the remote monitoring. So it gave patients, it empowered them and give them a more active role in monitoring their health status from home. So it also reduced the hospital visits that maybe were not that necessary, and also helped to prevent diseases. So I think it's an advancement that also the COVID helped. And regarding the education, I totally agree with Luis that it has to be a transversal topic, digital health in the curriculum, not just a subject. So health professionals should graduate with basic digital skills, but also with AI and machine learning. So it's not just that basic digital skills that were enough for 10 years ago. So we have to go a step further and make health professionals also digital professionals.
There was just one extra point I just wanted to raise quickly. I think that what the COVID pandemic did as well was increase everyone's awareness about the sort of risks around health information, like online information, that people became more aware about the potential for health information to not be reliable online and to be more aware of the need to sort of find trusted health information. And I think it also increased people's awareness about data privacy and data security, about how their data could potentially be used in ways that are harmful or violate their human rights. And that's given a lot of momentum to the things we were talking about before around data governance and AI governance. I think it's really helped to accelerate global and regional discussions on topics like that.
Thank you so much, Louise. I think we now don't have much time to take any more questions. Apologies. So I'll move on quickly to wrap up, and then I will give our panelists the conclusion remark. So we've talked so far about so many topics, actually. So it's going to be quite wrap up. So we've talked mainly about the notion of disruption of health systems, and that sometimes disruption is needed in order for us to transform from where we are at the moment to a more digitalized health system that would benefit the marginalized people, that will allow more access to healthcare, that will increase better or have better outcomes on patients' health in the future. We've also talked about the perceived notion that when you come from a high-income country, per se, you would have more digitalized health system, which is not the case. And some examples from the Global South do exist and have better outcomes or better integration of digital health or digitalization within health systems. We've managed to cover a lot of barriers that exist within health systems all over the world, from governance to barriers related to finances, to barriers related to the mindset of doctors themselves and their ability to respond to the digitalization. We've also managed to talk about the usage of data. Under what premises can we use data? How much can we protect the data that we have? And the idea of consent, the idea of data surveillance, the idea of its governance later on, and its security. And finally, we talked about the notion of keeping up with the pace of transformation. We are forever changing. 30 years ago, we weren't the same, or health systems weren't the same as we are at the moment, and it will continue to change in the future. And that requires an agile mindset, that requires commitment from leadership levels, that requires a system that, as Dr. Mahdi mentioned, that is dynamic, that is able to respond to that change in the future. And it also requires that all of the system is built upon the principles or the basic principles of human rights, that we are equitable to all, that the services are accessible to everybody around us. And I hope that I wrapped up most of the discussion points. And I will now give a concluding remark for each panelist to tell us exactly what do we get out of this discussion. I perhaps will start from my right side with Alba. Go ahead.
Okay, so my conclusion is that education is the basis for the transformation. So digital tools are nothing on its own. They have to be put into the productive way by health professionals. So the training and skills have to be changed. And also the heart of everything for me, it's data. So the policies have to be harmonized across the EU, and also training and basic skills about how to anonymize them and share them are basic for the health professionals. So these are my conclusions.
Yeah, thank you. So as it was said, there's so many aspects. What is it? There are always benefits and there are risks. And this is all about the medical profession is to not to harm the patients, not to increase the risks, but at the same time to actually find the ways how to make treatments more beneficial, more effective. Because if you look for the global sort of perspective, today we have an aging population nearly everywhere, maybe not only in Africa and maybe lesser in India, but if you look what happens in China already, the Vietnamese health minister of health 10 years ago said to me that in one occasion that our nation gets old before we get rich, and we see it's the same in Estonia, with our amount of percentage of the elderly people or people over 65, for example, will increase by 6%. From 20% to 26% in the next 20 years. So it's not realistic that we can deliver the same level of healthcare without actually taking advantage of the new tools, new approaches and data. And one good example to finish with is that actually, if we had a the approach how we could get the new vaccines was like up to 12 years of development. After COVID, we have now examples where the new vaccines were brought to the market in less than a year. And the next actual target, which is set up by international organization, is to be able to respond to new, actually emerging new epidemics in 1 month with a new vaccine. So without new technologies and data, it's not will be possible.
I just think the last thing that I would want to say is that the work of the Commission has really benefited from collaboration with IFMSA. It's really sort of highlighted the importance of bringing both the perspectives of young people, but also the future and current health workforce into discussions around the design and the governance of digital technologies and digital health policies. And that's something that we want to see strengthened, and we're looking forward to more collaboration. We're hoping to do some kind of workshops and discussions with IFMSA on what we're calling digital first health systems and what they should look like. So it's really important that we make sure that policy and design is far more inclusive, and it's collaboration with you that makes that happen.
So different science show to us today that the change is happening. So the digital health transformation is happening. I think that you have the opportunity to be leaders of this digital transformation and take it under your own responsibility rather than being the subject of this transformation. So you have this chance, which was not offered years ago. So it doesn't require a lot of efforts. It's very spontaneous things that need to be done, more awareness, more digital. You are all digital savvy, so it's meaning it should happen organically within the new generation. So I hope that you have better chance than what we got 20 years ago.
Theme event panel discussion. I'd like to thank the panelists so much for this enriching discussion, and also the audience for their interesting question. And we wrap up. Thank you all so much.
I'm really sorry. Thank you so much for the panelists for the amazing discussion. And before our participants go, we would like you to participate in a global digital compact input survey. And you may ask, what is the Global Digital Compact? It will be a document that UN will be working on, but to actually make sure that we have access to secure digital technologies. And before they create that that document, they basically need input. So IFMSA with External Affairs IT, they are collecting data from medical students. So please fill it out. So they could have something to share with the United Nations. Thank you so much. You can basically approach it here.
Now it's working, sorry. Let's make one big applause for our externals that joined us today here to share their experience about this interesting and important topic. Thank you. And also a big applause to Arva for moderating this event. Thank you.